I'm going to cover the goals of an anticoagulation management service, the indications for anticoagulation, rationale, efficacy, safety, duration of anticoagulation, talk a little bit more about selection of an anticoagulant and specifically whether it should be warfarin or one of the novel oral anticoagulants. And I will speak about the optimal use of anticoagulations, in particular renal function, which is very important for the novel oral anticoagulants because they're all metabolized by the kidneys, whereas warfarin is metabolized by the liver, and monitoring and reversibility. Okay, there are four major indications for anticoagulation: stroke prevention and atrial fibrillation, treatment of DVT and pulmonary embolism, prevention of DVT or pulmonary embolism after total hip or knee replacement, and coming along very soon, within the next year, prevention of a recurrent acute coronary syndrome. And when I say acute coronary syndrome, I mean myocardial infarction or unstable angina. One point about atrial fibrillation, as Dave said in the last session, it might account for 15% of all strokes, 20% of all strokes, but as we age, in the octogenarians and nonagenarians, atrial fibrillation actually accounts for up to 1 out of every 3 strokes. We have specific ways to predict the risk of stroke. The most famous scoring system we have is called the CHADS risk score. I do want to point out something important. If your CHADS score is 0, that doesn't mean you have 0 risk of stroke. You have a 2% chance per year of having a stroke, which I think is a pretty high risk. And the CHADS scoring system goes from 0 to 6. If you have a CHADS score of 6, your likelihood of a stroke is 18% per year, which is astronomically high. Now, most of our patients have CHADS with atrial fibrillation, have CHADS scores of 0, 1, or 2. And what's happened more recently, in Europe, a new scoring system has been developed called the CHADS VAS score. It keeps all the elements of the CHADS score, but it really focuses more on these patients who had only 0, 1, or 2 CHADS points, and it adds additional points. With the CHADS VAS score, if you're over 75 years old, you get 2 points instead of 1 point. And if you're 64 to 74 years of age, you get 1 point with this new CHADS VAS score. The VASC stands for vascular disease. So if you have had a heart attack or carotid disease or blockages in your leg arteries, you get a point for vascular disease. You get an extra point for age if you're, as I said. And then the SC in VASC stands for sex category. And why? If you're female, you get an extra point. Even though women have less atrial fibrillation in every age group than men, I am sorry to say, ladies, that women have more stroke from atrial fibrillation than men. So even though AF is less common in women, women are more likely to have a stroke from atrial fibrillation than men. And so this new, more sophisticated scoring system takes this into account. And now, instead of getting up to 6 points, you can get 9 points with the CHADS VASC. If you have a CHADS score of 1, your stroke risk is negligible. If you have a CHADS score of 2 or higher, it's generally accepted that anticoagulation is recommended. Now, with this new scoring system, what we're seeing in the future of anticoagulation is that the pie of patients with atrial fibrillation, which in the past had been about this big, with CHADS 1, CHADS 0, and CHADS greater than 2, and this CHADS 2 or greater is where you get our recommendation for lifelong anticoagulation. With the new scoring system, which is very well validated, now the pie of patients is first of all expanded. The number of patients is far greater, but the proportion in whom we are recommending anticoagulation is much greater because we're paying more attention to age as a risk factor, to female gender as a risk factor, and to vascular disease as a risk factor. I think also the concept has been that the anticoagulation management service is just a service dealing with warfarin and low molecular weight heparin or Lovenox. But the service of the future, our doctors of pharmacy who staff our anticoagulation service, they're going to have to, of course, keep up their knowledge of warfarin, but they're going to have to learn about dabigatran, apixaban, rivaroxaban, edoxaban, and I haven't talked yet about betrixaban, this particular novel oral anticoagulant, and I'm involved in a major trial of it, is primarily metabolized by the liver, not the kidneys. And the pharmacist in the future anticoagulation service is going to have to know all about the variable pharmacodynamic features of each of these agents. So I think to be a patient is going to be more challenging because you're going to have more questions to bring up with your physician about, should I be on a novel oral anticoagulant, and if so, which one of these many? And for the pharmacist working in the anticoagulation service, that pharmacist will have to know about the various differences in protein binding, half-life, renal elimination, and genetics of the different anticoagulants. Also, we are redefining how we assess bleeding risk. Basically, until now, as clinicians, we kind of eyeball our patients, learn about them, see if they look shaky when they walk, and say to ourselves, well, low bleeding risk, medium bleeding risk, high bleeding risk. There is a new scoring system from Europe that has the acronym, the HAS-BLED scoring system, which takes into account hypertension, abnormal liver or renal function, stroke, active bleeding history, whether the INRs have gone up and down a lot on warfarin, age, and the use of other drugs or alcohol, and puts this together and comes up with a validated scoring system. I think in the future, you're going to hear for atrial fibrillation patients, the doctor's going to tell you your CHADS score is this, your CHADS VAS score is that, and your HAS-BLED score for bleeding is this number. So this is what we're looking at in the future of anticoagulation. Now I want to tell you about what I consider the biggest game changer in the treatment of DVT and pulmonary embolism in my career. And it started in Europe with the EINSTEIN-DVT and pulmonary embolism trials, which are going to make a major impact on the way we handle acute DVT and acute pulmonary embolism. The DVT trials were published in the New England Journal in 2010, and the pulmonary embolism trial was published last month in the New England Journal of Medicine. Now Now, the program, Einstein, did separate studies of DVT patients and pulmonary embolism patients. So if you presented primarily with leg symptoms and had a DVT, you went into the DVT trial. If you presented primarily with shortness of breath and pulmonary embolism, you went into a pulmonary embolism trial. And the new treatment was rivaroxaban, one of the novel oral anticoagulants, given for the first 3 weeks in a high loading dose of 15 milligrams twice a day, and then in a maintenance dose of 20 milligrams once a day. This 20 milligram once a day dose is the same dose that the FDA has approved with rivaroxaban for stroke prevention and atrial fibrillation. The reason there is a loading dose is that we who are experts in the field of DVT and pulmonary embolism recognize that the first few weeks after a new DVT or new pulmonary embolism, the body is very hypercoagulable and wants to clot. And I think Henry Hagopian described very well that clot seemed to be building up minute by minute, hour by hour, as he got more and more pain in his legs because the body is very hypercoagulable. So you kind of have to put out and extinguish the fire of hypercoagulability, and that's done with this loading dose of rivaroxaban the first 3 weeks. That was for the DVT trials. For the pulmonary embolism trial, the same dose of rivaroxaban was given as for the DVT trial. And for both DVT and pulmonary embolism trials, the comparator against the rivaroxaban was enoxaparin, which is Lovenox, bridging over to warfarin. So we would say in Lovenox bridging to Coumadin. And for all these studies, the primary outcome event was symptomatic recurrent venous thromboembolism. So here are the results. I'm not going to tell you about the DVT trials and show the data on them, other than to say that rivaroxaban turned out the same as enoxaparin bridging to warfarin. The difference, the same in terms of effectiveness and the same in terms of safety. And the big difference is you never need to have any INRs with rivaroxaban. You don't need to have any adjustment of dose with rivaroxaban. You never have to have any injection with any needle touching your skin with any intravenous or subcutaneous anticoagulant with rivaroxaban, because once you take the capsule of rivaroxaban, within 1 or 2 hours, you are fully anticoagulated, just like with enoxaparin. You have an injection of enoxaparin, which is Lovenox. Within a couple of hours, you're fully anticoagulated. So the European equivalent of our FDA approved rivaroxaban for treatment of DVT this past December. So if we were in Europe and any of the 28 countries in Europe, I could prescribe for you rivaroxaban is approved by Europe, the European Union, for treatment of DVT. Now let's talk about the trial that was published in the New England Journal last month, the pulmonary embolism Einstein trial. It's the biggest trial ever done of acute pulmonary embolism patients, with 4,832 patients randomized to receive either enoxaparin bridging to warfarin or rivaroxaban, 3 weeks of a loading dose, and then 20 milligrams once daily thereafter. In terms of the primary endpoint of symptomatic recurrent DVT or pulmonary embolism, rivaroxaban was non-inferior to enoxaparin bridging to Coumadin. When you look at clinically important bleeding, rivaroxaban was non-inferior, or the same, basically, compared with enoxaparin bridging to Coumadin. But here is the most interesting point. If you look at major life-threatening bleeding, the rate of major life-threatening bleeding was 50%, 50% lower with rivaroxaban compared with enoxaparin bridging to Coumadin. Think what this means. Now we will have a new exclusively oral medication that we can use to treat acute pulmonary embolism without any injections, that is as effective as enoxaparin bridging to warfarin, but which has a 50% lower major bleeding rate. I'll give you two examples of what I mean by major bleeding. As I said, we physicians fear bleeding into the brain more than any other type of bleeding complication. And with enoxaparin bridging, with rivaroxaban in this trial of 4,832 patients, there was one patient who bled into the brain with rivaroxaban, compared in the enoxaparin bridging to warfarin group of 10 patients bleeding into the brain, 1 versus 10. Probably the bleeding complication we fear second most is what we call retroperitoneal hemorrhage. Not gastrointestinal bleeding where we can actually see the blood coming out the rectum or coming up through the mouth, but blood that silently but very quickly builds up in the abdominal cavity, which is often life-threatening or fatal because it's hard for us to diagnose, and it usually involves large quantities of blood loss. In the Einstein pulmonary embolism trial, one patient receiving rivaroxaban had a retroperitoneal hemorrhage compared with 7 patients on enoxaparin bridging to warfarin. So this, I believe that within the next 12 to 18 months, rivaroxaban will be available and licensed in the United States for treatment of acute DVT and a treatment of acute pulmonary embolism. Okay, next I want to talk about preventing pulmonary embolism after total hip or knee replacement. In the United States, there are about 1 million total hip or knee replacements each year. There are about twice as many total knee replacements as total hip replacements. And rivaroxaban is already FDA approved in the United States to prevent pulmonary embolism and DVT after total hip or knee replacement. For total hip replacement, the dose is 10 milligrams a day. That's half of the atrial fibrillation dose for 35 days. And for total knee replacement, it's 10 milligrams a day for 12 days. And that's it. No INRs, no warfarin, no Lovenox, nothing. And then the final area that I think is going to be in the future of anticoagulation is what we call acute coronary syndrome, and that's what I deal with a lot being a cardiologist. Each year in the United States, there are almost 1.2 million hospitalizations per year for acute coronary syndrome. And we call this in our lingo ACS. About 70% of the ACS hospitalizations are due to myocardial infarction, which is heart attack, and 30% or so are due to unstable angina, which is just about pre-heart attack. Men have more acute coronary syndrome than women, but in terms of equality, over the past 10 years or so, ladies, you've been catching up to us very quickly as you're smoking more and we're smoking less, and you're staying employed and stressed out more while the male gender is getting laid off from its jobs and having, in some respects, a lower stress level. But it's not quite equal yet. It's still 58% men, 42% women. But that 10 years from now, it may be 50-50. And acute coronary syndrome accounts for 134,000 deaths per year in the United States. The biggest problem with acute coronary syndrome is once you have an episode of myocardial infarction or unstable angina, over those next 6 months, you're really vulnerable to have another one because you're super hypercoagulable. With DVT or pulmonary embolism, that danger period is the first 3 weeks or so, and that's why I talked about the loading dose of rivaroxaban of 15 milligrams twice a day, a 30 milligram dose per day with rivaroxaban for DVT or pulmonary embolism. But the hypercoagulable state with acute coronary syndrome persists for at least 6 months. And the biggest way one dies or suffers a major complication is not necessarily the first heart attack or the first episode of unstable angina. Those are usually survivable. It's that you're at such high risk for another event within the next year or two. So a big trial was done called the ATLAS trial, and these results were just published at the beginning of this year in the New England Journal of Medicine. And the ATLAS trial was one of these mega trials of more than 15,000 patients who had suffered acute coronary syndrome. And they were getting all the different medications I mentioned that coronary patients get: statin, beta blocker, aspirin, clopidogrel, ACE inhibitor. So they were already on like 5 medications. And what ATLAS did is it took the patients and kept them all the medications and studied a 6th medication, which was rivaroxaban. So about 5,000 patients were randomized to a placebo or dummy pill for rivaroxaban. About another 5,000 patients were given ultra-low dose rivaroxaban, 2.5 milligrams twice a day. That's 1/4 the dose used for stroke prevention in atrial fibrillation. That's 1/2 the dose used for preventing pulmonary embolism after total hip or knee replacement. And about 5,000 patients were given low-dose rivaroxaban, which is 5 milligrams twice a day or 10 milligrams a day. That's basically the same dose used for prevention of pulmonary embolism after total hip or knee replacement. Now, I have to say, on the surface, it sounds kind of ridiculous that you'd even study rivaroxaban 2.5 milligrams twice a day. If I prescribe rivaroxaban, now it's FDA approved for stroke prevention, atrial fibrillation, I'm prescribing a 20 milligram capsule. 2.5 milligrams twice a day is basically licking the capsule a few times in the morning and at night, and you have your 2.5 milligram. I don't really fully understand why it was studied, but it seemed in some very small pilot studies to have some promise. Well, I don't want to keep you in suspense. The winner of these 3 groups, placebo versus ultra-low dose rivaroxaban versus low dose, was ultra-low dose rivaroxaban, 2.5 milligrams twice a day, did the following. It reduced the rate of cardiovascular death myocardial infarction or stroke by 16% over the ensuing 24 months of treatment. It reduced the risk of cardiovascular death by 34% after 2 years of treatment. And most important of all, rivaroxaban, 2.5 milligrams twice a day, on top of all the other standard medications that we prescribe for acute coronary syndrome, reduced all-cause death. All-cause mortality was reduced by 32% with rivaroxaban compared with placebo. I have no doubt that rivaroxaban will also, in the next year or so, receive FDA approval for preventing recurrent acute coronary syndrome. Now, warfarin's going to survive also. Excellent efficacy overall, low cost, a long track record, centralized anticoagulation clinics. There is now some new data that was just published in March that rapid turnaround genetic testing that's done within a few hours can help us prescribe a more precise initial dose of warfarin so that you can get into your therapeutic range of 2.0 to 3.0 with the INR more quickly. There'll be greater use of self-testing with point-of-care machines that are already covered by Medicare and virtually every medical insurance company. And those you can look at in more detail when we have lunch in the exhibits. And then there are new guidelines that if you're in one of those lucky few individuals whose INR is always 2.4, 2.5, 2.6, right where you want it, you might be able to spread out the testing to every 12 weeks instead of every 4 weeks. This genetic testing in this newly published paper looked quite amazing. They were able to get the time within the therapeutic range up to 71%, and that's a new record. Even the best anticoagulation management services have never been able to break the ceiling of 70% before. So in terms of the anticoagulation management service of the future, being staffed by doctors of pharmacy or registered nurses, they're going to have their work cut out for them. And so are we, the medical directors of these services. They'll need to know the indications for all the anticoagulants for stroke prevention and atrial fibrillation, for venous thromboembolism, by that I mean DVT and pulmonary embolism, and for acute coronary syndrome. They will need to know the details of the metabolism, the dosing, including the dosing for CKD, which is chronic kidney disease, and the duration of treatment for all these anticoagulants. They'll need to know how to assay drug levels, because over the next few years, though we don't have them now, there will become available a way to get emergency drug levels if we need them for dabigatran and rivaroxaban. And they'll have to know how to prescribe reversal agents if there is bleeding for all these anticoagulants. And although we don't have specific reversal agents yet for dabigatran and rivaroxaban, they're just around the corner. So I want to look into the future and make a couple of predictions. And then we can meet again and see how accurate these are. For stroke prevention and atrial fibrillation, I predict that as more and more Americans are switched over or newly started on the novel oral anticoagulants, we will see as a result fewer strokes across America and fewer head bleeds. For acute pulmonary embolism and acute deep vein thrombosis of the legs, I predict that as soon as it's FDA approved, that oral monotherapy with rivaroxaban, not using any low molecular weight heparin, no injectable enoxaparin, is going to catch on and become very popular. That consequently, because there'll be no intravenous heparin injections, and we won't have to hospitalize as patients as much for DVT and pulmonary embolism, that there'll be more outpatient treatment of DVT and pulmonary embolism. And I also predict, based on the Einstein pulmonary embolism trial, that there will be fewer admissions to the hospital with major bleeding complications. You'll remember warfarin was #1 for emergency hospitalization of any drug among those 65 years and older. And I predict that there'll be fewer episodes of major bleeding, fewer medical catastrophes of intracranial hemorrhage and retroperitoneal bleeding. I think rivaroxaban has already captured about 25% of the prevention market for preventing pulmonary embolism after total hip or knee replacement. In 4 head-to-head trials, it was more effective than enoxaparin. I predict that we're going to see fewer DVTs and fewer pulmonary embolism episodes after total hip and total knee replacement. I further predict that we will see improved survival after acute coronary syndrome because of a markedly lower rate of acute coronary syndrome with the prescription of this ultra-low dose of rivaroxaban. I think we will have the ability to measure and monitor the levels of these novel agents, which we'll only need to do under special circumstances, and that if there is bleeding, we will have an array of specific antidotes for these novel agents. So I think the future is very bright. Thank you very much.